Mr. Bettero. Thank you, Judge. Honestly, go fuck yourself, sir. You don't say that, okay? You don't lose a trial where a jury acquits someone and find them overwhelmingly not guilty and say, I gave my sincere obligation to look into this, and I'm telling you all I saw when she's guilty. Again, respectfully, go fuck yourself.
Is that a fair characterization? I think that, Your Honor.
I want to hear objection before I hear a word out of your mouth.
Objection.
Overruled. Sit down. Oh, I said overruled. Sit down.
Swear again like that. That was, no, I mean, whatever. That was, I shouldn't have done that.
A few moments later.
You, as a prosecutor, have got to be out of your fucking mind.
Nose.
Dude, Jimmy, look at those ears.
The ears don't bother me as much.
No, I don't trust a man. I don't trust a man with a lobe like that. No,
really,
not a fucking chance.
The mouth is butthole to me.
Very thin, paper thin.
The nose.
Oh, the nose.
The brows.
Well, listen, I will tell you though, I kind of like a fucked up nose on a guy.
Like a big old honker. I like a big nose.
Old nose. Give me that big bitch. You know,
yeah,
like, I'm into it.
Come over here, cluck cluck.
Yeah.
I see some chickens that went on up in my biz, cluck cluck. You gotta be with the kids, the kids, the kids, the kids, the kids, kids.
And I go, oop, clutch, clench, kegel. We did it all. And I go, oh, and what happened? And they go, well, we just got 4,000 plus pages, bitch. And I said, stop it. Show me it. Take me to Unimpound Town immediately, if not sooner. So what happens?
The bitch is here.
Why are you at a football game? Are you a Fonz correspondent?
Well, no, because it's only for men over 30. Okay? Have a great night, boys. Fuck off.
It's been 1 week since you looked at me.
Hey, Blues Clues, motherfucker.
Hello, lovies. Happy Sunday. Is it Sunday servicing solo time with me? Absolutely. Am I out of my tree? Per usual. What else is new? Where is everybody with like where the little comments live? Don't we usually put those on? I've lost them. I don't know. Found him. There you are. Karen Goldberg said this. Get your ass to the ocean. In the ocean, not to the ocean, around, about, near the ocean. I gotta ground. I have to focus. I've been out since 6 o'clock in the morning. That's a lie. 6:30. To go see patients, and I didn't get home till like after 12:30. And then children things, Lucy things. And then I was like, I want to be here so that I could talk about this. And there's a lot going on this afternoon, this evening on the YouTube streets. So let's do a Sunday afternoon delight. Could I do a trut to Old Orchard Beach or Maine? No. Nope. Don't have it in my spirit. Free Nurse Kim from 3 Jobs. God. Listen, I'm going to be independently wealthy eventually. And then it's over for you. I'll own an ocean. Just kidding. All right. Now I'm lost again. What is she doing? Kristen, that's our girl right on time. Yeah, she's on time. All right. Never. Okay. Thank you so much for loving that intro, Drake. And I am getting my shit together. Thank you so much, Kate, Coco, and Zeitgeist, too. We're going to go over what I think is the meat and potatoes of this case. This is everything. This is everything. The main event, if you will, babes. And it is not Tiny Mary and Tiny Jesus and the Boom. That's me. But it's going to be the psychiatric providers. And I think, in my humble opinion, is that Mr. Reddington is going to go to town on Monday. Ham, if you will. Not from Waltham, but he's going ham. Because the provider that was a community provider, not the inpatient at McLean, but Jennifer Tufts, the outpatient provider that had seen Lindsay intermittently since September of 2022 into January of 2023, she's a mess. And I mean that respectfully. Respectfully, ma'am, messy. All right. There's a couple of aha moments here. I hope the jury picked up on it. Mr. Reddington, please watch this show or not, but you got it by the canyons, if you ask me, on a lot of different elements. On your mark, get set, add it to stage. All right. Here we go. What is she doing? That is the download I need. We're going to make it big. Oh, professional. She just says nursing on, as a side hustle. We're starting at 111. And we always remember, babes, we like to do cross-examination because it gets into all of the meat and potatoes that the Commonwealth laid, their foundation. And then Mr. Reddington, defense attorney extraordinaire, is going to tear this apart. And this woman, Dr. Goodhart, I don't think saw this coming. And she's highly qualified. She trained in Brooklyn, went to medical school, then did a Harvard residency program for psych. Also, sidebar, she worked at Framingham State, like not the college, but the women's prison. It was the only prison for women in Massachusetts forever. We had a one spot. Imagine. You had people that had a second DUI and also infanticide, and husbandicide. So wild. She did that for a year. But very highly qualified provider. Also, so my algorithm is bananas at this point, and it's telling me all the things. And I'm like, bitch, figure it out. I'm doing it. And I'm learning about a new case. Well, it's not a new case. It's an old case. And it's actually very alarming to me because it's incredibly similar to Lindsay's. And there was a mother named Carol Goldberg. Nope. That's Karen Goldberg. Karen Coronado. Carol Coronado is the mother. And she unalived her 3 daughters in 2015. And she pled not guilty by reason of insanity. And she was like a lovely human being, like a very lovely human being prior to this unbelievable crime. And she had reached out for help. She didn't receive the help. And she actually had called her mother and left voicemails that morning of the crime. And they were heartbreaking to listen to. I'm not going to clearly have anyone listen to that with us, but it's so similar. It's so eerily similar. And she decided not to have a jury trial. She went with a bench trial, and the judge found her guilty. She had like a psychiatric break during her trial. She was like screaming and looking for her children and her husband. And she was the highest level security. She was in prison. And after she had unalived the girls, her 3 beautiful girls, she tried to unalive herself as well. So it happens more than is in the news. It's not like bad parenting like you see when you think of like a Casey Anthony, right? You think of like, oh, she had Zanny the nanny watching little Kaylee. Or you think of horrific outcomes. I think of Harmony Montgomery. I think of Adam Montgomery being the biggest piece of shit that has ever walked this earth. And crimes against children are devastating and should not happen. But in that same breath, when we see the outcomes in Lindsay of somebody who has a socioeconomic, one up on a lot of people, a career, a supportive family, a supportive husband, and just the idea that the prosecution is going to tell me that she just didn't want her life anymore. She didn't want to be a mom is never going to fly. And it's jarring that the United States of America, as a first world country, is one of the only countries that does not have an updated explanation or definition of mental illness and reason of insanity. We're still going by 1800s version of like, you did not know the crime. You did not know right from wrong in the criminal sense. And it's like, what? Meanwhile, if you're over in the UK, Australia, 41 other countries in Europe, they have an infanticide law that will take into account if a mother gave birth within the last year and she has a valid mental health diagnosis, that they will not charge her with homicide, but it is a manslaughter charge. Like, why are we so ass backwards? And I'm not saying that it can't be an excuse. And of course, evil people who do evil things to children should pay in perpetuity. Sign up with the devil, bitch, because you deserve it. It's just a really gray area here. And it's really hard to wrap your head around what you are thinking when you are looking at these beautiful babies and at Patrick and at Lindsay and seeing them all at a different time, and then what it devolved into. And with the avenues, the insurance, which was talked about too much on day 9, but she had like the best insurance. She was able to go, and they were like, just sign into the portal and talk about your symptoms. And it's like, I'd rather not. I just think that there is going to be change. And that's why it's important to keep covering it and to keep coming back and saying, oh, that's difficult. But if we don't talk about it, there will be more harm to children. And most staggeringly, there will be unaliving of mothers postpartum. That's the highest risk, is the self-checkout. And our country has the leading number of maternal suicides. Google that. There's problems, in my opinion. Bamber says, this trial is one of the most important trials, in my opinion. I do not feel Elsie is evil, and I think she could help other women if possible. I think her case will absolutely help other women in the future. And actually, this is interesting that you say this, Bamber, because someone had a very interesting take, and I want to know what you guys think. It was that, do you think that Lindsay Clancy was in worse shape because of the treatment she received? Like, had she not gone and got the medications, because the medication she had adverse and negative black box warnings to, right? She had these signs and symptoms that were horrific, that led to, in my opinion, but had she not received the inappropriate help and the non-diagnoses and all these medications in a 4-month time span, do you think that the outcome would have been the same? And that I can't opine on professionally. And immediately I said, no, of course she was better off because she got help. And then I was like, shit, I don't know. Kate Coco's that guy says, definitely think she was in a worse shape after having seen these providers. And Emily C, hey babe, says, and yes, I think because she didn't feel better after reaching out multiple times for help, it left her hopeless and in despair. 110%, Emily. Like, I sit there and I think after her inpatient stay with this doctor, right? Dr. Goodhart, ironic, we see that Lindsay knows that the history as a Massachusetts nurse, you look at fucking McLean Hospital, it is the gold standard. It's psychotic, but I'm just being dramatic. It is one of the most premier mental health facilities in our country. And do you think that after she left there and was worse, that she didn't think to herself, oh my God, I'm unfixable. I'm unfixable. I'm broken. I've been going to outpatient therapy and psychiatry. I've been going to those partial programs that I've attended, mother and infant and baby. I've been doing inpatient. I actually checked myself in because I was so fucking fucked up. Pardon my French. And I knew I couldn't handle it myself. And they let me go. I didn't leave AMA. They let me go. And I'm not any better. That's a lot. And Ms. Holmes says, she said, I'm never going to be the same again. That's so profound. And in our country, like, I think that it's just interesting because, like, since the 1980s, right, that was kind of the first generation. My mother was the first generation of working moms. And so you were supposed to be able to work. You were supposed to be able to take care of your kids. You were supposed to be able to take care of the house, take care of everything, take care of everybody and everything. And yes, you have support, but I feel like it falls a lot on us as moms. And you try to be good and you try to be perfect and you try to do the best job that you can when you're drowning. And I can relate to that drowning, especially when the girls were very little and having them 10 months apart. And working the weekends, doing, Baylor shift on the weekends. Former Mr. Nurse Kim being at work, away, traveling, because we were 16 and pregnant. We weren't. We were in our early 20s, but it was like, it felt like that. And so he would be gone Monday through Friday. I'd be with the kids, no stop. Olivia was up all night. She partied. Okay. Circadian rhythm of, I don't know, opposite. Tried to flip her in the bassinet. Nothing worked. Mia, angel baby, slept all night, was up all day. So I didn't sleep. And I remember calling my mom when Liv was maybe 5 months old and Mia was 15 months old. And me being like, I don't think I can drive to Market Basket because I'm so exhausted. And I'm crying. And you're just so overwhelmed and exhausted. And they need you for everything. I don't know. It's just heartbreaking. And we all can't do it all by ourselves. All the time. ATS News says they sell it as you can do it all, but somewhere it slacks, and usually it's the mom's mental health and health. Yeah, it's always your last on the list, I feel. My girls are now like 16 and 17 almost, and it's like starting to begin to put myself back on the list after that long. It felt like you have to go to a primary care doctor, Kim. You have to, okay? You have to. You can't just go when you need back surgery, when you slip and fall on a bowling, when you're out doing team building with work. It's crazy. And I think that no matter how educated or what you can give everybody else, or for myself at least, I can give others really great advice, but I can't do it myself, or I'm not going to implement it into my life because everybody is more important than me. But without taking care of you, you are no good to anyone else. Lesson learned in the trenches. Love you. Here she is, Dr. Alia Goodhart McLean.
Tapering or weaning her off Valium or an alternative to Valium?
Yes, I switched her from Valium to Ativan.
Okay.
Because it has a shorter half-life. And, you know, in my experience, it manages anxiety well.
And were you aware that she had taken Ativan before?
Yes.
And did she report any concerns about Ativan or benzodiazepines in general?
Yes.
What was the concern she reported to you?
She stated that her husband had concerns about her being on a benzodiazepine.
I see you, Queen.
During this interaction with her on the January 3rd, did you observe any signs of psychosis?
No.
And in the notes and the interactions with the providers prior to your meeting between January 1st and January 3rd, did anyone ever note any symptoms or concerns for psychosis?
No.
And you're aware that Ms. Clancy was also still in that, what was considered the postpartum period, right? She had had a child in May of 2022.
That's a tricky question to answer because different organizations or agencies.
Yeah. She was. Also, we are going to learn that postpartum depression and postpartum psychosis specifically, Mr. Reddington will say, is not even in the DSM-5, which is a manual that all psychiatric providers in our country utilize when in the treatment of psychiatric disorders. And C-Dub, what does, quote, half-life really mean when talking about meds? That's an awesome question. Your half-life is when half of the medication has been metabolized. So when it's in your system and when it's basically at its peak, okay? And then after that, the levels are going to drop. And she is saying it's a shorter acting half-life, meaning that Ativan would be able to provide relief for the anxiety quicker than the diazepam in her professional opinion. And that's what we use that for. Shorter half-lives are for instantaneous, like regular medications. And then XR would have longer half-lives. And some drugs just in general have half-lives for fucking ever. They stay in your system and you would test positive for them forever.
Assign postpartum a different length of time.
Okay, and so in your training experience and your experience as a person who diagnoses,
yes,
did you consider postpartum as part of what you had to figure out here with this patient, or was it really not a consideration?
It was.
Okay, and why was it for you?
I mean, she had a child, and the risk of postpartum depression, postpartum psychosis is a serious consideration.
Okay. Now, after this first meeting with...
Okay, spoiler alert. Sorry, I don't mean to do this to you guys. She never has treated a patient with postpartum psychosis in all of her time. And reminder, I told you in the beginning that she worked at a Massachusetts prison for women, the only one that we have. She was the director for a year. You've never... She was like, oh, probably would have stood out in my mind. Can't recall. Babe, if you don't know how long a postpartum period is, if you don't know if it's in the DSM-5, if you don't know if it's going to be, or there is question or pushing for it to be in the DSM-6, what are we doing here? Also, sidebar. I wanted to get to this question. Burn Bright Karen, thank you so much, Lovey, says for the $27.99 Canadian. Kim, I was fast tapered off Zoloft 2 days after the taper, driving on a highway, and I had a clear message to slam the van into a concrete barrier with my 4 kids in the vehicle. 20 years later, this still terrifies me. Okay, come close. Confession. Confession time. Has no one else had an intrusive thought like that? Because I have. I remember this was right when I was telling you guys in the beginning that like I had Livy. So both of my daughters were born in 2010, one in February, one in December. Busy year. And I was like, oh. And I mean, like, so happy. You're so joyful. But at the same time, you're like, holy guacamole. I am the most overwhelmed I have ever been as a human being. Also, babe, I just turned 24. I was an infant myself. And not really, but in my mind. And we had gone up to Fun World, up to Guilford. And one of my best friends in the whole wide world, Jay Con, she was up there with her daughter, Caroline. And Caroline was like 5 months older than Mia. So I brought both the girls up and I'm coming back. I remember like it was yesterday. I'm in the freaking blue Ford Explorer that I had. And I am driving. And I have like this thought of like, oh, like I'm not going to make it home. And I was like, what the was that? And the kid, I wasn't thinking like specifically about the kids. I was just like, oh, I'm not going to make it home. I'm not making it home today. And I, again, hadn't slept that whole night. I was trying to like keep, because Mia's sleeping, Livy's up partying all night long. I'm like, woo. And I'm trying to like enjoy being up here in the fall, up north, and like being with one of my best friends and her child. And all I'm doing is like ready to cry in the car, being like, this is not good. I didn't get maybe a wink of sleep that night. And my mom helped me there too, because like she ended up having to come over because like I needed a shower and like a nap. I think I slept for like 18 hours. And like my bladder was so full. I like woke up to have to pee because I was just like running on fumes is not even it, you know? And then I had so much anxiety. Like I was so worried that like, are you breathing? Are you okay to the babies? That I would make myself nuts over that as well. I was so anxious. And that's when I got a diagnosis of postpartum anxiety. It was rapid succession children, but it also was intrinsic. Like I am highly susceptible to anxiety. And then I also think there was like biological hormonal changes, duh. And then the extrinsic factors of you're young, you're trying to make ends meet, you can barely pay your rent, and now you have 2 children. It was wild. So I get that, and I see you and I hear you. And it is terrifying. Okay.
Ms. Clancy, on the 3rd, were you able to give her in your own opinion, a diagnosis?
Yes.
And what was that?
You said after the 3rd?
Right.
Okay. So that would mean one meeting.
Yes.
I gave her a diagnosis of insomnia with a mental health condition because one day of observation wasn't sufficient for me to figure out if she truly, to give a solid diagnosis because it sticks with the patient.
Right. Fair to say you just didn't have enough information at that point.
Correct.
Right? Okay.
So she's like, I didn't have enough information because she just came in and we just listened to everything she said and we did no actual investigation into your previous mental health conditions and or outreaches to suicide hotlines or what you had been treated in the community. While we have a database in Massachusetts, I know this why, because I go in it all the time for medications, specifically controlled meds are in our MassPat, but also you are able to have systems that show you what prescribers have prescribed to a patient. It's wild. This woman is wild, in my opinion. Nurse Kim, can you please explain why Ms. Bo Peep, aka Buckingham, what the buck, keeps mentioning Lindsay's speech pattern? Is she saying if she was having an episode, then her speech would be slurred or something? Great question, sweet and spicy. She's actually trying to say that Lindsay was not, in fact, bipolar. She is trying to pull the wool over everyone's eyes by saying without pressured speech, which is someone who's boop, 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 like go, 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 and never let you get a word in edgewise, that without that specific speech pattern, then you are not actually in a manic phase. Hashtag not true. Hashtag, hashtag this one's for you, Bo Peep. So she's not thinking it's slurred. She's just saying that because it wasn't rapid and that she had linear thought process, meaning she made sense, not nonsensical or, ideas of grandeur or other telltale signs in regards to speech, that basically Lindsay's a faker, which is not true. Thank you for asking.
I have a concern about her leaving on.
Just kidding. We're going to go to 140.
Just to them.
Why not?
Oh, Mr. Eddington.
Evaluation and the notes that were available to me since January 1st at McLean.
Now, as a psychiatrist, I mean, when she goes to the hospital, she's your patient, right?
Mm-hmm.
She's your patient.
Yes.
Yes. And as a doctor, what you want to do is get all the information that's available on why this person is in your locked ward, right?
Yes.
So did you do inquiry into her prior history, or was that left to the CEC person or the social worker?
That is part of the evaluation.
And the evaluation is CEC?
And when I see her as well.
All right. So do you...
Stop it. Emily C., stop it. Mr. Reddington? Interview? What? I know you're busy. Talk to you soon. Doing great. Keep it up.
Sometimes when I say you, I mean you or the social worker or the CEC person. Do you talk to people like third party? I think you said third party contacts?
Yes.
All right.
Watch this.
The social worker does.
Okay. So, and you reviewed the records. So
what a typical fucking doctor too, to be, no, sorry guys, to be like, yeah, do you contact other people to get a history and background? And she's like, yeah, the social worker does. Like, God forbid, you haven't done anything. You know who you usually ask to do that? Your nurses.
When did the social worker talk to the first psychiatrist that she went to see?
The social worker contacted Patrick.
Oh.
Well, I know you told us that he contacted Patrick and that Patrick gave some history about the benzodiazepines that he was concerned about and he thought she wasn't getting good medical care. Is that correct?
Yes.
All right. You know that she had medical treatment before she came to McLean?
Yes.
Okay. Who was her psychiatrist?
The nurse practitioner she was seeing prior to coming to McLean, I was aware of that person.
Would that be nurse practitioner Gelada?
Yes.
Oh,
did you speak to her?
Gelada.
No.
Did you look at her records?
I did not have access to them.
Why not?
They aren't in the same medical record system.
Well, the same medical record system is just so that you have access to MGH, you have access to Brigham and Women's Hospital, because it's all part of some big computer information access you have. What about other healthcare providers? Can you get access to their records?
Yes.
Not immediately.
Well, how about if you have a release signed by a patient under the HIPAA law? You know what the HIPAA law is?
All you need is a release. One piece of paper, fax it over, You get the notes. Stop.
Is obviously, right?
Yes.
And then just tell me, what does that actually mean, that a patient allows someone to look at their medical records?
Yes.
And Lindsay was very, very cooperative with you guys, wasn't she?
Yes.
Did anyone ever ask her to sign a HIPAA release for anyone to get access to nurse practitioner Gelada's records?
No.
How about
What?
psychiatrist Tufts' records?
No.
How about nurse practitioner Paul's records?
No.
Who's Letitia Dukes?
She was a social worker, I think, that Lindsay saw at South Shore
I
at the
did.
perinatal program.
Okay. And do you know when she went to the South Shore, Rhode Island perinatal program?
I know it was prior to admission. I don't remember the exact dates.
Do you know what recommendations that she had received at that point?
No.
It's so wild to me, guys, because you're thinking to yourselves, well, really, is it their job? Or maybe you're thinking to yourself, is it their job? Is it McLean's job to follow up and see what other treatments, modalities, prescriptions, etc., and the past medical history of Lindsay? Yeah, it is. Period. Full stop. It is. This was an inpatient stay. This isn't like she went from one practice to another and she was like, oh, I hate my therapist. I'm going to find a new one, betterhelp.com. I'm looking it up in the white pages. No. You signed yourself in voluntarily to a psych hospital. And they didn't ask for any history from those other offices or partial programs. It's terrifying.
Other than the medication.
Do you know what medication she was actually on when she presented to McLean Hospital?
Seroquel and Valium.
What is it?
Seroquel and Valium.
You knew that Dr. Tufts was the first psychiatrist that she actually consulted, correct?
I believe so.
And when again, if you don't know, just say you don't know.
Yes.
Okay. And I think you made reference to the fact, or maybe the DA made reference in questioning you about the fact that she was looking for doctors for some type of medication or something. Is that fair?
That's a very vague statement. I don't know what you mean.
Okay. Well, actually, she saw Dr. Tufts because Dr. Tufts advertised that she was an expert in perinatal care, right?
Correction.
Overruled.
Oh, sorry.
Derek, if you're not trolling, why? I think that there's an admission of harm and of guilt to what happened and the unaliving of her children. There is an admission there. But you don't believe that she didn't have the capacity to know what she was doing when she did it? Or are you just trolling me?
I wouldn't know why she saw Dr. Tufts.
Do you know what medication Dr. Tufts prescribed to her?
From what Lindsay told me, yes.
What?
Zoloft was.
So Dr. Tufts, according to Lindsay, with Zoloft, which is an SSRI, correct?
It's an antidepressant in that class, yes.
Okay, so when you say an antidepressant in that class, the class would be selective serotonin reuptake inhibitor, right?
Very proud of you. Mr. Reddington knows all this shit. This is insane that this provider is going to say everything that I did, everything that I acted upon while she was inpatient was a direct report from the patient. It's glaringly obvious that they 100% dropped the ball in the treatment of Lindsay Clancy.
Yes.
And that's pretty powerful stuff, isn't it?
I don't know what you mean by powerful.
No? Well, are you supposed to prescribe Zoloft or sertraline to a person that has bipolar?
I think it all depends on what you're seeing when you see the patient.
All right. So it's important, I would imagine, then, to be fair in your evaluation of this young woman that came to your hospital for help on New Year's to find out what any evaluations were of her condition, her presentation, her symptomology when she saw that first psychiatrist, Dr. Tufts, right?
Lindsay was cooperative and she was forthcoming. I had no reason to think that she would not provide us with what other providers thought, just like she told.
Hey, babe. Hey, babe. Sorry, Dr. Goodhart. Quick question. Lindsay was forthcoming. Lindsay was telling the truth. All wonderful things. Lindsay also signed herself in voluntarily to a psychiatric facility. I'm going to need you to get a little bit more information than from the patient that voluntarily checked in. Come on.
Told us that Tufts said she was worried about bipolar disorder. And
I apologize.
Yeah.
Tufts advised her that she was worried
no,
about?
sorry, it was
Gelada?
yes.
Okay.
Sorry, thank you.
That's all right, no problem. And again, if you have records, you want to look at them, that's fine, because I know it's tough to have all this stuff in your head.
Yes. Thank you.
And so Dr. Tufts prescribed the Zoloft to her, and you knew that right after the initial prescription of Zoloft. Do you know how many milligrams she was prescribed initially by Dr. Tufts?
Lindsay, I think, stated it was 25.
Okay. And then Dr. Tufts increased it to what, 100?
Lindsay said it was increased to 50.
50, all right. So, and again, you're in a, I don't know if it's appropriate to say, but you're in a mental institution, right? That's where you work at McLean
Yes.
Hospital. Okay, and it's a...
The text revision? Yeah. She didn't know the diet. I thought it was more telling Anne Marie, Canada, that she just didn't know that postpartum was not in the DSM, postpartum psychosis, and that there is a push to have it added to the DSM-6, which is coming out, I believe, in January.
Locked ward, right?
Yes.
And she's a patient that's coming to you for help, right?
Yes.
Is it appropriate for a doctor to take what that patient is telling you as a history?
Thanks, Sam.
Or do you have to verify it or talk to other healthcare providers to make sure that they're not just running off and making something up?
I had no reason to believe that she was not a reliable reporter.
Because she seemed very forthright, right?
I had no reason to believe that she wasn't a reliable reporter. There is no words. There is no words how unbelievably neglectful this entire testimony is. And that you expected Lindsay Clancy to give you every single bit of information as the entire picture when she's asking for help. And you were like, yeah, no worries.
Yes.
She seemed very honest in her disclosure of her symptomology, right?
Yes.
One of the things, or one of the tools that you in the mental health field have access to is psychiatric testing, right?
Yes.
Okay. You have, for example, one tool, and I think psychologists, and there are psychologists that are on staff, I would imagine, at McLean as well.
No, not on that unit.
As a psychiatrist, you don't administer psychiatric or psychological testing, do you?
No.
All right. But for example, you've got the Beck inventory test, or what's called the MMPI test. You're familiar with those, right?
These are forms and forms that the patient can fill out.
Right. And one of the tests is the MMPI, which is Minnesota Multiphasic Personality Inventory Test, right?
I have heard of that.
Okay. And you know that one of the things that it determines is if they call it the K scale, whether or not somebody is lying or minimizing, or not minimizing, but lying about their symptomology, right?
I don't know much about the scale.
Well, that's a tool that...
Sorry, JK. I was trying to be nice and not chew. I don't know about the tools. I don't know about the scales. I don't know about patient-reported symptoms. I don't know via assessment tools. What do you know? The Muffin Man?
Can give someone information as
Yes.
to the person's presentation of their symptomology. That would be important as to their honesty of whether or not they're trying to minimize or whether or not they're trying to falsely project their symptomology, right?
I don't know
From your lips to God's ears, Diane G.
what you're asking me.
Okay. Were you aware that there were ever any psychological testing administered to Lindsay? MMPI or Becker? Okay. How many?
This was big.
I don't know.
Wouldn't that be?
I don't know how many times Lindsay Clancy had reached out to a self-checkout hotline. Also, please note, everybody, at the bottom of the ticker today, there is the National Maternity Mental Health Hotline, and it is 24 hours a day, 7 days a week. If you or someone you know is struggling, please feel free to reach out, 1-833-TLC-MAMA.
Something important to find out if the person who you're suggesting was denying suicidality or suicidal ideation upon your evaluation that she called out to suicide hotlines?
She was telling, she told us that she was having suicidal thoughts,
Right.
but had no intent or plan. So I do know that she was struggling with suicidal ideation.
Right. Anybody else that you talked to? Or did you
Patrick.
talk to anybody else?
I know the social worker, Dr. Patrick, and he did give the information he gave.
Okay. So what I'm asking is, as you're investigating the history.
So that's a cop-out. And as somebody who works in mental health, I just will say this to you guys. If your patient says, I don't have a plan, but you are suffering from SI, which is self-checkout ideation, that's still passive. Okay? Just because you can say, I can contract for safety right now. That's what I ask at a patient when I see patients. Can you contract? Are you able to contract for safety at home and in the community right now? And if that changes, who are you going to call? And they're like, you. And I'm like, whoa. I'm like, yes, you can call me, but you also got to call so there is saying that she wasn't suicidal, but that she was having ideation is an absolute cop-out from a provider.
Of this patient. You're not aware, no idea that she had reached out on not one but two occasions to a suicide hotline. Is that correct?
Twice.
Yes.
All right.
Now she knows.
Did you know that when she was first prescribed the Zoloft by Dr. Tufts at 25 milligrams, then increased to 50 milligrams, that she then reported that she was unable to sleep?
She
for
shared
40
that with us. Yeah,
Was that-
sorry. I'm sorry. I
Go
didn't.
right ahead, no problem. What is it?
I'm going to let you finish the question.
Okay, thank you. No big deal. It's just that she reported that she went for 48 hours without sleep.
I don't remember that time quoted. I know she had difficulty sleeping.
You indicated in your testimony that, and I quote, I would have preferred to have more information about her sleep patterns, right? Do you remember saying that?
Following the changes in the medications that we were making.
So sleep pattern would be just what it says, sleep pattern. Like you sleep from 9 at night till 7 in the morning or
Yes.
12 at night, whatever your pattern would be, right?
Yes.
And why is a sleep pattern important for you as a psychiatrist trying to evaluate your patient?
Because difficulty sleeping is a symptom of several different conditions, and it can worsen several different conditions.
And it can be life-threatening. For you to stay up for 48 hours and not being on meth, which also could be life-threatening in certain circumstances. But if you are up for 48 hours and you don't need sleep, if you think you are like exhausted, and like I always say, I haven't slept since 2010 when I had my kids, right? But I have. I've gotten like 4 or 5 hours probably after they were 2. Before that, no. And I still don't sleep because I have racing thoughts at night, like, or not racing thoughts, like I just can't turn my brain off at night. So I'll look up at the ceiling and I'll be like, oh, I have to pay that. Or I'll be like, oh shit, on Saturday I have a party. Or, oh God, I have to sign this form for Liv. Or, oh, Mia needs to get this new thing for school or project. It's just gone on. It's a brain. Your brain never shuts down. And the fact is that over extended periods of time, lack of sleep, not just insomnia, but exhaustion, lack of sleep can lead to really negative outcomes. And for all of us, we have to figure our sleep schedule out. If you don't sleep well, figure it out. We really got to meditate, or we have to do something, because it is really impeding on your overall health, not just your mental health, but all of your health. And this provider is like, yeah, so she has a effed up sleep pattern. Don't make it weird. I just kept giving her more drugs that should have actually, tranquilized a full-grown elephant, and she was still awake.
And you know that she had reported severe anxiety, right?
She was struggling with anxiety, yes.
Struggling with anxiety. And she was having not just insomnia, but she had very, very severe insomnia, didn't she?
She wasn't able.
Oh, Father Smith, I'm so sorry. Yes, she is. The training and experience that this provider, Dr. Goodhart, has is very high. She's highly qualified, but her application, like all people, right? There's good nurses, there's bad nurses, there's good psychiatrists, there's bad psychiatrists, there's good cops, there's bad cops. I think this is a lazy, negligent provider, but her knowledge, training, and experience is very, very qualified.
To sleep.
And you would prefer to have more information about sleep patterns, is what you said. I'm not putting words in your mouth. That's what you said.
I know that we were able to observe her sleep while she was on the unit. Once she left the unit, I would not know how she was sleeping, which is why we referred her to somebody else so that they could continue to monitor her symptoms.
Obviously. So let's put the time that you are observing her, or that your social workers are investigating, to whatever extent they did, her background. What were her sleep patterns that were important to you prior to New Year's 2023?
The amount of sleep is important.
Yeah, and you said that. You already said I would have preferred to have more information about her sleep patterns.
After she was in, if I was going to continue to evaluate her, I would want to observe her sleep.
Oh, that's what you meant. Oh. That's what you meant, but you didn't document it like that. And Tufts is even worse with documentation. So let me get to 204. I want to talk thyroid because it's important postpartum and also just women's health in general.
A woman who is involved with postpartum, right?
I think it's to assess the level of depression.
In a woman who's involved with postpartum, not some guy that got injured on a soccer field, right?
Yes.
So what does the EPDS mean? I'm probably butchering that. What is that in an acronym for?
Edinburgh's postpartum depression scale or something.
Okay. The Edinburgh postpartum depression scale.
Scale or something. You love to hear that from a testifying witness.
Was that administered to Lindsay when she was in for the 4 days and a half that she was in your hospital?
No.
Why not?
Mr. Reddington, can you please stand by the mic, please, and thank you in advance?
Because we don't necessarily administer scales.
You don't necessarily what?
We don't administer scales.
Why? That's an accepted tool to evaluate a patient as a psychiatrist or a psychologist, isn't it?
Sure is.
It is a tool, but it doesn't in the end
You also may be a tool, ma'am.
determine the diagnosis.
No, of course not, because the doctor who supposedly has access to the person's medical history and all of the other aspects of your evaluation is the one that gives the diagnosis, right?
The psychiatrist makes the diagnosis based on the presentation, the history of the patient.
Right. So far what we've got.
Which you didn't have. Okay, so how the patient presents, what the patient tells you, and the history, which you did not have. So, ma'am, you're actually quite right this moment. I think that your foot went directly into your mouth, and that will be used against you in your civil lawsuit.
is a presentation of the patient who was in the locked wards at McLean Hospital, and the presentation was from her, right?
Her presentation is how she presents, how she is observed. It's not what she's telling us.
Well, isn't what she's telling you part of what you consider?
Yes.
Okay. And what Patrick's telling you is part of what you consider?
Yes.
So other than what Lindsay, who is in the locked ward, tells you, and her husband who tells you, what, if any, investigation did you do?
We did not do any additional collateral contact.
Admission.
And you didn't do any tests either, right? You didn't do it. Did you do a blood test?
Psychiatry as a field is not dependent on blood tests. If it was that simple, it would be much better for everybody. It's based on the evaluation of the patient who's sitting in front of you.
So,
okay, yes, ma'am. We obviously don't use everything like textbook, right? So a gallbladder or you needing your appendix out, there is certain signs and symptoms you look for in most all cases. Psych is very different. It's very patient specific. Everyone can be different. The presentation is one of the most important parts, but history is the best predictor of the future. Can I get an amen? You didn't do any of that. It's shameful.
So you're suggesting to this jury that it's not a valid medical step for one to take blood from a person who is on a cocktail of drug medications
Amen.
to find out what their levels are?
No, not a regular procedure at all.
Okay. Now, McLean did not take any blood. McLean did not do.
She's so full of shit up to her eyeballs too, because you would at least do a tox screen. You would do a tox screen. And if she was on benzos, which she was, Valium, then you would want to know, is she taking it or is she selling it on a black market? Stop it. Why are you full of shit? And we know that she was toxic. Oh God, what am I saying? Not quetiapine. Her Seroquel levels were through the GD roof. This is after the incident. But it's unimaginable that you didn't do at least like, did you not want to see if she was on illicit drugs and checked herself into a psych ward? You would not want to see if she had ETOH, aka alcohol in her system? Stop. Of course you would.
The Edinburgh scale, but that would be something that you would be interested in, right? As to whether or not anyone else gave her the Edinburgh depression scale.
Let me clarify one thing. McLean did draw blood. They did do testing. There was no testing for levels of drugs. Just
okay.
Let me clarify that. So
That's fine.
Okay.
So they took a CBC or maybe a blood count evaluation, but it had nothing to do with what was on board, as they say, as far as tricyclics, antipsychotics, SSRIs, anything, right?
They check for substances of abuse.
Oh, good.
But nothing else.
Well, there were no substances of abuse in her blood, were there?
No.
How about the tricyclics, the antipsychotics, the SSRIs, the benzodiazepines, the Z drugs that they call some of their categories? They didn't test for that, did they?
Those are not tested on a regular basis.
How about on her basis?
Patient specific. I don't know. What do you know? Nothing. Next. There was something about her thyroid I wanted to say. Hi, Lindsay. Oh.
Exhibit out of the courtroom.
I think it's probably best if you want to look at it, keep that in the courtroom.
Yeah, okay. Yeah. Right. So you can look at it, but just you'd have to stay.
Go look at it. Tell him, Big Red.
Counsel, redirect?
All right, redirect.
Prevention Lifeline, right?
Yes.
No, I don't care about that. What else did she say?
Observations of her.
Absolutely.
And was there anything inconsistent about what she was reporting to what your observations of her were?
No.
When she arrived.
Well, then your insurance shouldn't pay you for the entire stay. I would like to get it. It's fraud. Because if a patient is telling you everything and you do nothing for her and you allow her to leave early so that she can get home for her daughter's birthday and she feels absolutely hopeless because she just went to the premier psychiatric facility, not only in the Commonwealth, but in the country. And you said, here, let me write you some more prescriptions and you can just, that's what they said to her. Fraud, waste, and abuse.
At McLean, you were advised of what medication she had been on, correct?
Yes.
And any of the treatment plans that you or any of your colleagues recommended, did they require different medications?
I'm not sure I understand your question.
Well, you were asked about the blood work.
Yes.
And so you indicated that McLean does draw blood upon admission, right?
Yes.
But that you did not look at the blood work or ask or evaluate it for levels of medications.
Correct.
Was there any reason to do that based on the medication regimen that you were advised that she had been on?
No.
And with your treatment plan as far as medication, would there have been a reason to do that to either verify or not verify that she already had things in her system?
No.
You were asked on cross-examination about the defendant reporting that she complained of brain fog or being foggy. Do you recall that?
Yes.
Do you also recall that she was observed by nurses to have improved memory and improved concentration, over the time that she had been at McLean?
Yes.
You were asked on cross-examination about suicide hotline. And are you familiar with suicide hotlines?
Yes.
And what do they assess for when you call one?
Imminent, like risk. And if somebody's calling and they're feeling suicidal, I think the point is for them to send somebody or to help them through it.
And also in Massachusetts, we have what's called a BEST team, and that can be deployed for people in crisis as well. It's actually kind of rare. It's psychiatric intervention that is able to evaluate and send either our patients to crisis stabilization units like Marie's Place or Advocates in Framingham. Like there's a lot of different options, but a crisis, a suicide hotline is specifically when you are having feelings of self-checkout. Thank you, ma'am. So this provider let us know that McLean Hospital has taken a turn for the worst. Do you know, do any of you have family members, because I do, that went to McLean for like substance abuse? Sorry, it's not funny, but like the 90s were a wild time. And like people would have like lobster, and it was like they would go to McLean and it'd be like top tier. It was like no one else was like that. And they had programs that were so impactful and helpful for substance use disorder. And you could go for like 28 days. And then you get a book and they would help you like for aftercare. And I remember my family member just being like, they had the best food. And I was like, okay, well, that's not really what you want to think about. But now I look at the providers and it's not encouraging. There's nothing encouraging that you are going to help those who come to you, who seek it, and that are not there. I feel like they would have treated her differently if she was a Section 12. If she was an involuntary admission, they would have done the research. But because she was proactive with it and was like, this is alarming, I am out of control and need help, they were like, oh, okay, so tell us everything. We're going to take your word as gospel. We're not going to see what anyone else has done previously. And I'm going to make med changes and send you on your merry way. What could go wrong?
It's a point of interest.
All right. Now, 329. Is that right? No, I'm a lie. I want to do 309. Now, this is Tufts. And this is tough. This is a tough watch, if you ask me. This bitch, I'm like, you're leaving a lot to be desired.
She was worried about having side effects. And did she mention?
Okay, so Tufts is, she went to medical school in Vermont. She did post-grad at Boston Medical Center for 4 years. She just became an actual psychiatrist in 2022. And she works for Astro. I don't know for how long. She's going to still be there.
Which specific side effects or just side effects in general?
I thought it was in general.
And as a result of that concern, is that when you went over the potential side effects of Zoloft?
Yes.
And after having that discussion and you explaining the side effects of Zoloft, how did the two of you leave it in terms of whether she was going to take the medication or not?
I told her what my recommendation was, that she should start the sertraline. I'm not
I'm sorry,
sure if she told me definitively if she was going to take it or not. She might have needed some time to think about it.
And based on your evaluation with Miss Clancy, everything you learned about her history and how she presented that day, did you have an initial diagnosis?
Yes.
And what was that?
It was a generalized anxiety disorder, and it was an adjustment disorder with depressed mood.
What is
this bitch? That's what she has for diagnoses. Stop it. First time I ever heard it. GAD, generalized anxiety disorder. Look it up. ICD-10 code. Couldn't give it up, but I think it's an F. Okay. And here was the kicker. Adjustment disorder with depressive features, but mixed, because clearly this lady isn't doing a lot of digging either. And every single thing that she's going to say when she talks about assessment, I'm going to clap the frig back. Clap back. All nurses, I know you were like, shut up. You did not just say that. She gave the most broad overview of what you are looking for in a psych patient, and as it relates to diagnoses and the help that she provided. P.S. Way to really knock it out of the park with your 17-minute visits and then making med adjustments. 17 minutes. Ew.
Generalized anxiety disorder?
It's an anxiety disorder where an
General?
individual may have a lot of different worries. They may also have physical feelings of anxiety, but they're worried about a lot of things, not really just one thing specifically.
Yeah, that's all of us.
And what is adjustment disorder with depressed mood?
So adjustment disorder refers to a fact that there may be symptoms, but they are kind of secondary to the situation. So they don't meet the full criteria, say, of a major depressive disorder, but there were some symptoms of depression.
Is this a good place to start? All right, members of the jury, this is, it's 1 o'clock. We're going to take the afternoon recess. I'm going to ask you to be ready to come back.
She was like, saved by the lunch bell, because I need to go look up what a generalized or an adjustment disorder is with non-specific features. Stop it. Stop it. She's having a difficulty adjusting to motherhood. She's been a mother for 5 years. What's the adjustment? What are you talking about? This was an improper diagnosis. Duh. All right, now we're going to 319. Where's 319? 319.
And furthermore, you wrote that the baby needing more attention, other kids more challenging too. Is that coming from the patient?
Yes.
And does she also describe she's having trouble leaving the baby, too anxious to do anything when she leaves, physical tension, heart racing, worries he won't eat or sleep because he's refusing the bottle?
Yes.
Okay. Hi. Everything that is described in that little paragraph, I am worried about the baby. They were calling her controlling, right? The Commonwealth is going to say she was a highly controlling parent. She's worried about the baby. She's concerned he won't take the bottle. Do you know how much stress that puts on a parent, on a mother, not eating, not sleeping, and then concerned of nourishment, especially when she is an actual maternal baby nurse? She's a mother infant nurse. And now she herself has a baby that she is like, oh God. I think that parents, and everybody can parent their own way, but I had to have specific schedules because, again, I had one nocturnal child and I had a vampire and a day walker. And like if I didn't adhere within like minutes, I would regret everything for the next 3.5 days. So you're seeing this and you're going to see that this is going to escalate. She's like, it's no biggie.
And did she say that makes her irritable?
Yes.
And in that same note is where you detailed that she denied audio hallucinations, visual hallucinations. You also, correct?
Yes.
And you also detail suicidal ideation, homicidal ideation, denies no concern about hurting baby. Is the no concern about hurting baby, is that an observation you're making or something that came from Ms. Clancy?
It came from our conversation.
You're full of shit. She is absolutely, look at this liar. That's a lying liar who lies. And I want to tell you why. As a medical professional, what are you going to say? If this was a conversation that happened, right? She would have said, asked question and patient responded, or she would have said, patient states, quote. So this was her, we'll continue to monitor. A reminder. We used to put that on all of our notes. Now we can't. But back in the olden days, we would say, we'll continue to monitor. It's a throwaway line. She wrote that, I'm sure, in every single one of her notes. And she goes, oh, that came from the conversation I had with Lindsay. Well, then you would have put a statement that the patient said to you. I call bullshit.
So at some point in time, she told you she had no concerns about harming the baby.
Yes, it was.
Object. Just an objection? You could rephrase that question.
What did she tell you about her thoughts about the baby?
I asked if there were those thoughts, and she denied them.
Oh, then you would have said that.
And did you also provide information to her about what to do if in between appointments
this
there
blew
were
my
emergencies
mind.
or issues?
Yes, I believe that I did. I usually do when I meet a patient.
And
I believe I did. I usually do. If anything comes up in between our appointments, all right, Lindsay, don't worry. I want you to listen to this. Oh, anytime now. Find your home. No? Is it me? Am I the problem? Well, that was going to be a little bit more of a dramatic effect than we looked for, babes. Just keep pressing. No? All right, we'll go to 320.
Yeah, just this plan section. Yes.
Just the treatment plan section.
Yes.
So is it that she would have to search through the records, or is that?
Oh, wait, we got to go back a little bit. Can we do it again?
I believe that I did. I usually do when I meet a patient.
Here we go.
And in the page describing treatment follow-up plan, which would be in the initial diagnostic assessment from September 15th in that treatment follow-up plan section, is there a part? There's a part there that says, if having urges to harm self or others, go to the nearest emergency room, call 911, or call the National Suicide Prevention and Crisis Hotline. Correct?
Yes.
Is this page given to the patient?
They can access it online on the portal.
They can access it on their portal. You dummies. What are you having, a mental health emergency? I want you to log in to your Circle Health Care. Put in your password. It's got to be 12 characters, 2 specials, a capital and a lowercase. What are you talking about? They can access it. Thanks.
So Ms. Clancy would have the ability to go on here, look at the portal, and see what to do if she was having a crisis.
Yeah, just this this plan section. Yes.
Just the treatment plan section.
Yes.
So is it that she would have to search through the records, or is that something you can click on to see the treatment plan?
I'm not sure exactly what it looks like for a patient.
Okay, but that's one of the sections.
I have no idea. When I was trained, we don't give a shit what the patients see. Me as a provider, I've never looked it up. But that's what they told me when I came here to testify.
That's available to the patient, Lindsay Clancy, if she goes onto the portal.
Yes.
There's also in here, if you feel you're in crisis, you may text home to a certain text number from anywhere in the United States. Is that correct?
Yes.
And what does that do when you text that text number you text home to that text number?
It connects you to a counselor.
Now, what was the treatment or follow-up plan for Ms. Clancy?
To start the sertraline, to start individual therapy, and to follow up with myself.
So your recommendation wasn't just that she take pills, you recommended that she attend therapy, correct?
Yes.
With what time? Did no one ask this, or does nobody think about this? With what time is a mother of 3 who is a registered nurse, who has a brand new baby, who is struggling with mental health issues, who is trying to keep her life together, who has a husband, who has a family, who is doing all the things? When is she going to say, you know what, I'd love to put in an hour to go talk to somebody? With what time? But that was your treatment plan. It wasn't just pills. I also recommended she did talk therapy, behavioral therapy. Okay. That's about as useful as tits on a bull.
And when you recommended the therapy, did you, and the medication, did you also go over with Ms. Clancy alternatives to the medication that you were recommending?
I believe she was aware that the alternative was that she could not take a medication, which is what she had been doing before.
Or don't.
And after you went over all of this information with Ms. Clancy, did she convey to you that she understood the plan and was agreeable to the plan?
Yes.
What is informed consent?
Informed consent means you communicate with a patient what the risks and benefits are of treatment, and they
Decent explanation.
understand that and they agree to the treatment.
And did Ms. Clancy show that she had informed consent to everything you discussed?
Yes.
Now, was your next appointment with Ms. Clancy on September 28th, 2022?
Yes, it was.
And so during that appointment, did you discuss the medication, the Zoloft, that you had prescribed to her?
Yes.
And what did you learn from Ms. Clancy about whether or not she had taken that medication?
She shared that she decided not to take it.
Did she tell you that she had picked it up but had decided not to take it?
All patients have the right to refuse, babes. Remember that. You can be prescribed something, but you have the right to refuse if you are competent.
Yes.
Did she tell you how she was feeling?
Like
She
shit.
said a little bit better.
And did she elaborate on that?
The baby was getting some more sleep, so she was also able to get some more sleep, and that helped her feel better.
And at this appointment, did you go through a mental status exam of Ms. Clancy?
Yes.
And what is a mental status exam?
So a mental status exam is an assessment of the patient at the point of meeting. It can change at different times, but it's comprehensive, referring to how the patient appears, how they cooperate, how they speak, how they describe their thoughts, how they're able to communicate with you, and what their mood is like.
And do you
Silly says, I respectfully disagree. I think therapy is an important piece to psych meds. Now, with telehealth, I feel like they're having an hour at home isn't the worst thing. Here's the only thing is I 100% agree. You should have cognitive behavioral therapy. Everybody should, all of us, right? Sign up. All I'm saying is that when that is presented, there are certain aspects and certain times in which, although you might want to do that, that is going to be the last thing on your bingo card of what you have bandwidth for, right? Like when you're going through it, when you can barely get up and you're struggling with so many different things. As a parent and going as a mother going through postpartum, just a depression, not just, but and a depression, then your physiological changes, your physical changes, your mood, and being so exhausted. I think that she could have even made appointments, but her being able to sit down and go through with those CBT, cognitive behavioral therapy, at that time was probably a little bit much to ask for her. She went and did her absolutely the partial outpatient programs where she did almost days, like, you do half a day there and you sit and you do group. She did a lot because she knew that it was needed. But when you're trying to schedule in one thing a week for yourself, that hour, would you rather go to do yoga and take your pills, or would you go to sit down with somebody that you don't know, explain everything for the 19th time to another person about, like, oh God, I have to tell my whole entire story again. And it can just be daunting, I think, to some patients. It just in my experience and my opinion. I don't think you're wrong at all.
Do that at every appointment with every patient?
Yes.
And so on the September 28th, 2022, when you met with Lindsay Clancy for that second meeting, did you do a mental status examination?
Yes, I did.
And what was the result of that?
So is it okay if I read it from the note, or do you just want me to?
There's no objection.
Go ahead, you may.
She was alert. She was oriented. She was appropriate. Her rapport, meaning how she worked with me, was appropriate. Dressed appropriately. Euthymic, meaning not depressed, not angry, kind of a normal mood. Her affect was full. Her speech was appropriate. Her thought content and process were appropriate. She did not mention any hallucinations. At this point, I mentioned her insight was poor. Her judgment was excellent. Her cognition.
Her insight was poor. She documented it. Now, that's not, we had the conversation, throwaway line, no bad thoughts to baby. Her insight was poor. Now, let's hear her explanation for that.
Did not show any deficits, and there was normal psychomotor activity.
And why did you list that her insight was poor?
So I think that must have been related to the fact that at this point, she did have some very clinically significant anxiety. Usually when people come to a psychiatrist, they believe that their symptoms are significant and that a medication is something that might be prescribed. But despite these symptoms, she still didn't want to try the medicine.
And what is the difference between a psychiatrist and a psychologist?
So isn't that interesting? The Commonwealth is going to tell us that she's doctor shopping. She wants all the drugs. Meanwhile, Tufts is like, I can't get her to take anything. So which one is it? Also, she's getting worse if she has poor insight. And she knows that.
So a psychiatrist is a medical doctor. We go to medical school and then we specialize in psychiatry. A psychologist does not go to medical school. They may do a lot of research in their training. They may learn a lot about psychotherapy, but they don't learn about the human body, about how we metabolize medications and things like that.
Mm-hmm. And so can a psychiatrist prescribe medication?
Yes.
Can a psychologist prescribe medication?
No.
Now, in the medical records, Exhibit 219, page 47, it lists here recent lab work, no lab results were found. Is it that you had ordered lab work and you couldn't find the results, or that none were ordered?
None were ordered.
And why is that?
It was not necessary.
And why isn't it necessary at that point for Ms. Clancy to order blood work?
There's no blood work that is commonly done when a patient presents with generalized anxiety disorder and no other medical complications.
What types of situations would you order blood work for?
I mean, there could be a lot. Certain medications require laboratory monitoring. Maybe something that,
Lithium, Clozaril. Those are like psych medications that you would think out the gate that you would need a blood level for. Also, just general medications. You could think of Coumadin, etc.
Could affect the kidneys or could affect the thyroid, could affect the cholesterol. These are things that we monitor to make sure that the medicine is prescribed safely.
And so Zoloft, is that not one of the ones that would need to be monitored because of its potential effects on the body?
Correct.
And at that time, she reported to you she wasn't even taking it yet, correct?
Correct.
And your appointment that day, I think according to the records, it was approximately 17 minutes long. Is that correct?
So
Here it
can I
is.
explain that?
Absolutely.
Because I think there's a bit of a misunderstanding. So the 17 minutes, I think people are looking at the note where it says a therapy start time of 10 a.m., a therapy end time of 10:17. So they're calculating 17 minutes. But those timestamps are specifically related to the therapy portion of the exam. They're not reflective of the complete duration of time when I met with her.
You shut your stop it. Stop. Jennifer. What? You are so full of shit. You know that damn right well that you ended that visit and you clicked off. It was done in 17 minutes. But let's hear this word salad.
So what would be the complete time that you met with her on that day?
So I don't know the exact amount of minutes, but the appointments are 25-minute appointments. So it would be more or less a few minutes, about 25.
And so the 17 minutes that are for the therapy portion of the appointment, what comprises therapy? What does that involve?
It really varies based on the person, based on the situation. It can involve, providing some emotional support.
I apologize. Can we talk about Lindsay Clancy rather than in general? That's all.
I'm going to allow a little bit of the background.
I love Mr. Reddington there was like, hey, yeah, can we not do generalizations? Can we bring this back? Reel this in back to Lindsay, please.
So then we'll move into the defendant.
Thank you. So you were saying that therapy portion is kind of talking to the patient, seeing how they are, and getting an assessment of their current mental state?
Yes.
And the other 8 minutes, typically, what happens in those 8 minutes?
That's more focused on specifically medications and medication management.
So these appointments that you had with Lindsay Clancy, when it says 17 minutes, that's the therapy, the talk portion of the appointment, and then there was a separate portion where medication was discussed?
Yes, in the real world, those two segments are intertwined. So it's not necessarily that we say, this is the end of your therapy component. It's a bit more seamless than that.
Okay, so she was getting therapy. She was getting therapy with you for 17 minutes, but not really because her entire appointment happened in 17 minutes. You just had a 25-minute block. And why would you need to make the differentiation between what we're doing with medication is completely separate from your talk portion? Because you would be asking her signs and symptoms. How is she sleeping? How are you doing? How is she presenting? You'd look at her. Is her affect flat? All the things that she just talked about. You would be doing a visual assessment while hearing her, while deciding with the patient, if appropriate, to make adjustments. And to be frank, a lot of people in the chat were like, that's 3 times what my psych provider has given me. Unfortunately, that is very true. And that some people are in and out in 5-10 minutes. And I don't think that you really should be, I don't know. I'm not a psychiatrist, but that's wild that you're able to do all of that in 5 to 10 minutes.
Now, in your training experience and the way you conduct your practice, if you're having a therapy portion or you're conducting therapy with a client and that 25 minutes has run out, is it a hard stop or is there an option to continue?
It's not a hard stop. I do have limitations because I have other patients that are waiting. But if there's something urgent, I can go a little bit over. If there's an emergency, I can cancel the next patient if I have to.
And
Nuh-uh. Nope. I call BS on that too. No, you wouldn't. You would have put that out. You would have called 911. You would have had her taken out and you would have got to your next patient, because that's, unfortunately, the United States healthcare system is patients are numbers. And how much numbers and productivity are you making for your office, and how much money is the practice making? Somebody also put a comment that Jennifer had just become a psychiatrist, I think in 2022. She'd been doing it for a couple of months as an independent queen. Mistakes were made. Why didn't she have a preceptor? You should have been fucking precepted for a year or 6 months. No? Remember getting out of nursing school, guys?
these 25-minute appointments that you have, if a patient were to request a longer appointment with you, is that available?
It's an option.
Did Lindsay Clancy ever request a longer appointment time with you?
No.
Now, that appointment on September 28th, 2022, was that also a virtual appointment?
Yes.
Oh.
And did Ms. Clancy appear to be alone in that virtual appointment?
Yes.
And based on
She was
your
crying in the
conversations
bathroom.
and assessment
Nope,
of
that
her
was me.
on that day, what was the plan going forward?
So at this point, she was improving, and we decided to pause on the medication question and have her meet with one of our therapists.
So that first appointment was on September 15th. You recommended therapy. The next appointment was September 28th. So had Lindsay not scheduled a therapy appointment yet with Jennifer McAllister at that point?
I'm not sure when she called to schedule that.
And but
Great. Now we're gonna go bopping down. Do.
sure if you asked her about
No.
as a psychiatrist, when you're prescribing a medication like Ativan and you're telling a patient to take as needed, what does that mean?
So it means when the symptoms are present, and in this case in particular, when the symptoms are severe.
So with Ms. Clancy, what were the symptoms that she was experiencing that made you decide that Ativan would be an appropriate medication?
Anxiety.
So would it be when she was feeling anxious, feeling those symptoms of anxiety, that she should take the medication?
Yes.
And what was the dose again?
0.5.
What's the lowest dose of Ativan you can give?
0.25.
What's the highest dose?
Maybe 2.
Wait, did you just say? Huh.
So you started her at the lowest dose, the 0.5.
Yes.
And was there a specific time frame that you wanted her to try this in?
Yes,
Was the
this was
access
for
limited?
1 week.
And was the prescription for a 1 week amount, or is it hard to tell that because it's as needed?
It's hard to tell that without seeing exactly how many pills were prescribed.
And was there also, again, a recommendation to go to Ms. McAllister for therapy?
Yes.
And when were you recommending follow-up with Ms. Clancy?
1 week.
And
1
why
week.
a short turnaround at this point?
Because she was still having very significant symptoms.
And did you in fact see her on October 26, 2022?
Yes.
So now they're going to go through, babes, and they're doing all of the stuff, all of the visits. You're seeing that Lindsay is clinically getting worse, not improving. We're doing med changes, adjustments. She's doing other programs, like she went to Rhode Island. She did that inpatient stay. I mean, not inpatient. That's a outpatient partial program. She is really trying. And then she goes to McLean on New Year's. And now we're going to listen to her, meaning Tufts, discuss like the last time she saw her, because this is chilling.
Did she also tell you, and this is a quote in the records on page 144, I think it's my problem. I keep reaching out to different people and not sticking with the plan.
That's what I documented.
And did you discuss that with her, that concern that she kept reaching out to different people and wouldn't stick with the plan?
Yes, I advised that she have one person who is managing the medications.
And why is that important?
So that it's very clear what's happening.
It's also for continuity of care, continuity of patient care, to ensure that everything is going through one provider equals safety.
And what is the importance, if any, of sticking with a plan, a mental health plan?
Well, the importance of sticking with a plan, obviously the psychiatrist comes up with a plan for very particular reasons. And so, sticking with the plan is advisable.
When you prescribed...
Yeah, it's advisable, but if it's not, then we should have punted and done something different. What were the reasons? What was the hangups? Why didn't you dig into that deeper? What's up, babe? Why are you having this? Like, okay, we keep talking about this. You can lead a horse to water, but you can't make them drink. Saying that we know. But this is a horse that quite literally drinks. She's like not a wild stallion. She's just out here trying to do it. And like, she is following the plan of care, but then there's a fear component. The anxiety is getting worse. She's not feeling better. And she says, maybe the problem is with me. I would look that as persecution. Like that she's like, I'm bad. Not about the plan, not about sticking to the plan. Read between the lines. You're a fucking psych provider.
Psychiatric medications. Do those medications take effect immediately?
No.
How do they? How does that effect start to happen in a person?
Well, it depends which medicine. Some medicines do work very quickly, like the benzodiazepines, Ativan and Klonopin. But the medicines that prevent anxiety, the medicines that prevent depression, those do take a long time to actually kick in.
And why is that?
So the way that the medications interact with the brain, the serotonin receptors, the way that they change the neurotransmitters, it takes time for those changes to happen.
Now, was there? Did you also talk to Ms. Clancy about bipolar disorder that day?
Yes.
And why did you do that?
So it was mentioned because of the poor reaction she had to some of her medications, the insomnia.
So you had a red flag. You already knew? That's interesting. You talked to her about bipolar because of the reactions she had to meds. Huh.
So we discussed whether these side effects she was experiencing indicated she had bipolar disorder. But when that was assessed, it was not deemed that she had bipolar disorder.
And why was that?
Because she really didn't meet the criteria.
And what criteria didn't she meet?
So there's a number of different criteria for bipolar disorder, or specifically looking at mania, because she did have some symptoms of depression, but the other side is mania. So the most important one is euphoria. So actually 7 days of continued euphoria with very high energy levels. That's the most important one. But then in addition to that, you need some other things like potentially.
That's a lie. That's a lie. It is not always euphoria. How many of our manic patients are as paranoid as all get out? You don't have to be euphoric to have bipolar. Oh, what? You've given medication that should have been able to knock out an elephant and she's still irritable. Irritability. Insomnia. Flat affect. Hello? You're not always just her impulsivity. Is she up cleaning? Is she up feeling badly? Is she feeling guilty? Is she fighting with Patrick?
Pressured speech, grandiosity, which is like a person feeling superhuman or godlike. You might see increased risk-taking behaviors. Usually those are significant risks, like somebody having affairs or using drugs, things that really negatively impact their life.
So if she was banging a neighbor and ripping lines of cocaine, you would have diagnosed her. But because she was buttoned up and because she didn't meet like every single symptom, and you have whatever was in your brain as a 4-year-old brand new baby psychiatrist. I'm thinking that we make sure that we know that everybody can present differently. It's not a one size fits all. Bipolar 1, bipolar 2. Hypomania. That is very concerning.
Person might have a decreased need for sleep, which is not just insomnia, but it's truly not needing the sleep and having enormous amounts of energy otherwise.
What is
pressured Or you're a mom.
It means talking very fast, so fast that it's really hard to interrupt them.
And did you ask Ms. Clancy on December 1st questions that would potentially elicit whether or not she met that criteria?
Yes.
And did any of her responses to your questions indicate any instances of mania in her past or present?
No.
You know, that's also wrong because I don't know if I passed it, but guys, we also find out that in nursing school, Lindsay was on Prozac. And I can relate because in nursing school, I went on Paxil because I had anxiety about reading diagnoses in books. I thought I had cancer. Stop. Don't make fun. Stop it. You can't make fun of me. I hypochondriaced my ass into a Paxil, like a 3-month Paxil situation. Because I was like, I don't know if I'm going to be able to go through this. Like, I was like, I'm reading everything. And I was like, could be, possibly, maybe. I was a what? Well, still am, but a little bit I was unhinged. And they were like, oh, she's an anxious queen. And I was like, you know it. Did a little Paxil. Jumped right off of it because I'm highly sensitive to the medicina. And then I was done that chapter. But geez, I get it. And if you have a history of being an anxious queen or a depressed queen, then we sometimes can have reoccurrence of that. And we're at a higher susceptibility than another who hasn't. Facts matter.
What was the plan going forward from that day?
So at this point, she was still seeing the doctors or the providers at South Shore. And so they were still managing her medications. So the plan was that she had an appointment with them tomorrow. She was considering taking the considering taking the Seroquel without the Remeron because she had had side effects with that, but that wasn't decided on. That was something to consider. And we also talked about starting a medicine called lamotrigine. I just gave her some information about the medicine. And we also talked about her going to a partial hospitalization program, which provides extra support for people who are really struggling.
Lamotrigine, is that Lamictal?
Yes.
And did you prescribe it to her that day or just discuss that option with her?
Just discussed on that day.
Why did you discuss that option with her?
Because it was clear that she had depressive symptoms and she was not tolerating some of the other antidepressants. So I thought that that might be another option to explore.
And you also discussed with her a partial hospitalization program?
Yes.
And why did you do that?
Because she was really having a hard time. She had, mentioned those thoughts of feeling hopeless and the intrusive thoughts. So I referred her to a program that was
having those thoughts, intrusive thoughts. They're what? That's impulsivity. Like you have to see a picture clearly for what it is and the other factors that may affect your patients.
Would provide extra support. It would be a program that she went to every single day, not hospitalized. She could still stay at home and be with her family, but that she would have all day care every day for
day program.
As long.
About the women and infants program in Rhode Island.
Yes.
And what did she tell you about that?
She said that she was referred and appointments were being scheduled.
And were you familiar with that program?
I've heard about it.
What type of program is it?
It's one of those partial hospitalization programs that I had mentioned, but it is focused on postpartum. So I thought that that was a good fit.
You thought that that was a good fit, but you didn't give her a diagnosis of postpartum depression. What? Weird. She has general anxiety disorder and adjustment disorder.
So the plan was for her to go to this women and infants program. Depressed, and we had a plan to address that.
Is there something you can do if you have a patient who you think is at risk of harming themselves or others?
Yes.
And what is that?
I could issue a Section 12, which would mandate that they be brought to a hospital for treatment, or at least for evaluation and then possible treatment.
And did you feel that was necessary at that time with Ms. Clancy?
No.
And when you're evaluating a patient, taking the history, looking at their current state, looking at what the answers they give you to the questions, are you reliant on the information that they give you?
Yes.
So if a patient withholds important information, is it hard to make a diagnosis or a plan?
Yes.
Was your next appointment with Ms. Clancy on January 9th, 2023?
Yes.
And what was discussed at that appointment?
So she said that the trazodone increase was helpful. She was still getting that rebound anxiety the day after she took the Ativan. The mood was okay, but she was feeling like she was still flat. She wasn't able to cry, but she said she was able to laugh a little bit, and hadn't been having recent thoughts of suicidal ideation.
Had not been?
Had not been.
And did you also ask her if she had any homicidal ideation?
Yes.
And what was her response?
No.
Did you notice any signs or symptoms of psychosis?
No, I did not.
Did you have a discussion with her about trying an antidepressant?
Yes, I did.
And what was that discussion?
So at this point, she had been off of the Seroquel for a couple weeks, and she wasn't getting better. So I thought that suggested the Seroquel might not have been what was causing depression, and it was depression. So that was what we needed to treat.
And what were your suggestions for treatment of the depression?
We considered some different options. We didn't pick a medicine on that date, but we considered amitriptyline and Wellbutrin.
And Wellbutrin was one of the medications she had taken when she was in nursing school, correct?
Yes.
You did
Okay, so we have a history.
medications on the 9th. Why wasn't a decision made that day?
Because we had made a different medication change because of that rebound anxiety with the Ativan. We decided to switch that to diazepam, which is Valium.
Hold on. She went on to the Valium. They just did so much med changes. It's wild. And this is only from, guys, remember, all of these med changes and all of these heavy hitting, not narcotic, but heavy hitting psychiatric drugs, including not only antidepressants, anti-anxiety. We have atypical antidepressants in the trazodone for sleep, Remeron, adding that in, wild. Then we're throwing in Seroquel, an antipsychotic medication for a woman who has never taken it before in her life, a 32-year-old mother of 3, a registered nurse that probably weighs $125 on a good day. You had her up to 300 milligrams of Seroquel. Babes, you wouldn't have your complex PTSD veterans sometimes on that much. And she still couldn't sleep. But you never thought bipolar. Ma'am.
To try the amitriptyline.
And what is amitriptyline?
So it is a tricyclic antidepressant.
What does that mean?
It's an older antidepressant that's been around for very many years. It helps treat insomnia and some pain, headache conditions as well.
And the dose that you prescribed, did you say it was 10 milligrams?
Yes.
Is that the lowest dose?
Yes.
What's the highest dose?
Can get quite high, maybe 150.
And so again,
maybe.
Why was it that throughout this time treating her and trying these different medications that you always start at the lowest dose with her?
That's standard practice because the medic.
Well, thank you so much for asking, Buckingham, because that's actually the way it works. Okay, that's how they practice medicine. And you can't just walk in and say, I would like to give somebody 300 milligrams of Seroquel. Wait, she did in a couple of months. That's insane. I'll never get over the fact. Listen, everything else I can try to get right with. And I'm like, all right, so she needed some sort of benzo to help her. Did she need multiple? No, probably not, but whatevs. Antidepressants, sure. Seeing that you're having reactions, not awesome. But that's Seroquel. If that doesn't make a shiver go down your spine, that you have no pre-existing history, no PTSD diagnosis, no nothing, and yet you couldn't take a nap, when you would probably able to not even obtain a heartbeat on me if I took that, and I'm a big ol' thickums, okay? I'd see you next week.
They have side effects, and the lower the dose, the more mild the side effect. And then you gradually increase it depending on how you're rating it.
And what was the plan going? Well, strike that. What was her mood and affect that day?
It was depressed. Affect was depressed.
And with psychosis, were there any grounds for you or any reason for you to seek a Section 12?
No.
Your next appointment with her was January 23rd, 2023. Is that correct?
Yes.
And
The day before. This is it. This is the end of the road for today, lovies. This is the day before the unalivings. And this is what Dr. Jennifer Tufts, psychiatrist, documented.
again, all of these appointments were virtual appointments, correct?
Yes.
During this appointment, what was her mood and affect?
Mood was depressed, affect was depressed and flat.
Did she tell you she had started the amitriptyline?
She did.
And did she tell you if there were any side effects to that?
It didn't appear that there were side effects.
What was the conversation or interaction with her that day on the 23rd?
So she said she was doing all right, a little more anxious, and the anxiety was just described as the feeling of her heart racing. She had a decreased appetite as well.
Heart racing is a sign of mania.
She was
Decreased appetite is a sign of mania.
on only 2 milligrams of Valium at this point and feeling more anxious in the morning. Mood was the same, flat, anxious, no motivation, numb. She has to...
No motivation, numb. The day before the unthinkable happened.
force herself to get out of bed and out of the house, but is able to do that. And she is sleeping okay.
And did you ask her if she had suicidal ideation or homicidal ideation on the 23rd?
Yes, I did.
What was her response?
No.
And did you notice any symptoms or signs of psychosis that day?
No.
Was there any difference in her rate of speech or speech pattern?
No.
Was there any difference in her ability to think or communicate in any way?
No.
Was there any change in her your evaluation of her judgment or insight?
No.
Do you think you could have missed it? Yes. Do you think that if you've only seen somebody for a couple of months and you don't have a real baseline and you're doing telehealth visits that you could miss something? Yes. The key to a therapeutic provider and patient relationship, in my opinion, babes, is like I see my patients. And when COVID happened, I was muffed because I was like, shit, get me out, because I was like scared of being in a facility. And then once I was out in a case management, I was like, oh, great. And then I just noticed that, like, although you can do the most that you can virtually, it's not in person. And I think that we're missing that. We're missing that as providers. I'm still out. The most rewarding and most challenging job I've ever had is one that I still love and I still do. One of three jobs is home care, psych home care. Obsessed. Why? People let you in. You can't hide what's going on because you can't put a background behind you. You can't virtually cover it up. I see what's going on, what is seen and what is unseen. Are you having a hard time keeping up with? And listen, and I'm not a judgy bitch, you know this. So I'm just here to help you. I'm just here for you. But I see what you're going through. And then I can talk to you about it. And you can tell me to go pound sand, or you can have a moment because I'm the only person that you see, and you can tell me and I can help. That is healthcare. That is why we got into it. To be of service, to heal, first do no harm. I feel like it is lost via a virtual component. And I think that she should have at least had a couple of visits in person.
Did you still consider her insight poor at that point?
I did.
And why were you still considering her insight poor?
So I think there were just a couple of things that came up throughout our 14
Like
visits that suggested that to me. Like I explained earlier, but later on, it was it had to do with her over attribution, it seemed, to the medications about certain symptoms that she was feeling, meaning like how she felt about the Seroquel, how she felt that that was making her depressed, when in reality, I think she was just depressed. So it was related to her thoughts about medications and how she was feeling.
So would it be accurate to state that instead of accepting that she was depressed, she was placing the blame on the medication?
Sustained.
And is that not something that somebody who is not accepting of their condition at the time and maybe trying to mask because they've masked for so long, is that not unnatural? Oh, it's this med, try another one. And you can't get fixed, and you go to McLean and you're not fixed. And you come to that realization on the 23rd. Well, no, on the 4th, whenever you're leaving the hospital, and you're saying, I'm now on my own and I've got to pick myself up by the bootstraps and figure it out. And yet there were more med changes made. And yet there was more missed. And nothing will ever replace in-person patient care. You'll never tell me different. Thank you to Maynard 20785 for our discussion today. I appreciate you.
In your mental status exam of her on the 23rd, how was her appearance?
She was appropriately dressed.
How was your rapport with her?
It was appropriate.
How was her speech?
It was appropriate.
How was her?
Business on the top, party on the bottom. How do you know? How do you know her house wasn't in disarray? How do you know she didn't have 15 Diet Coke cans on her desk? I'm not talking about myself. I'm not projecting. I only have one. And a Canada Dry. Like, you don't know because you're allowed to see what you're allowed to see.
Thought content and process.
Appropriate.
How was her cognitive abilities?
There were no deficits.
And her psychomotor activity?
Normal.
What was the plan going forward on that day?
So we were going to continue the same dose of the diazepam because she was feeling a bit more of the anxiety. So we said to slow down the taper, and we increased the amitriptyline to 20 milligrams.
Why wouldn't we?
Thinking that that would also help with the sleep.
And at any point in time, did she tell you she was planning to kill herself?
No.
At any point in time on the 23rd, did she say she was planning to kill her children?
No, absolutely not.
At any point in time during your interaction with her in that session, was there anything about her affect or demeanor, her behavior that indicated to you that she was a danger to herself or others?
No.
Well. I just want to tell you that was meant to be a puncture hole, a punch, if you will, to the defense. It's not. It's not at all. Did you know? Did she say that she was a threat to her harm, a threat of harm to herself or others? Is she a risk? No. Did she say she was going to harm herself or her children? No. There was no plan because, in my opinion, Lindsay Clancy had a break. In my opinion, when you asked your husband to go pick up her Pedialyte for your daughter, Cora, you still are her mother and you are still planning for the future, and you know that you need to deal with constipation. Constipation, not a killer. Something snapped. And psychosis is quick. It can be extensive. It can be quick. That could have happened in minutes. And the pain in which she must feel every day that she wakes up, not only physically, spiritually, emotionally, but having to replay and know that your beautiful 3 babies are no longer on this earth because of your actions and your hand is a fate worse than death, in my opinion.
Was there any reason, based on your evaluation of her in that that session, that would give you grounds to file a Section 12 on her that day?
No.
throughout your time treating Miss Clancy, did you continue to recommend that she attend individual therapy?
Yes.
And why is that?
It's very important.
And is there a reason it's important, or like what are the benefits?
Yeah, it has. Many studies have been done to show the efficacy of therapy as a component of treatment for depression and anxiety.
Mhm.
So, some people may only do medicine, some people may only do therapy, but the best response is a combination.
Sure is.
Thank you, doctor. I have nothing further.
Okay, Kevin Ruddington is about to, Monday morning, he's going to dance on her. I hope she wears a bow, babe, because he's about to come take her to church. Notes. There was something that I could not download because my computer is sinful, okay? And it refuses. I fight a desktop, but I need you to watch this. There was a moment that the judge said this. Now I'm going to turn it up. Oh, shit. Are you going to be able to hear it? Listen.
Well, it is at least inferred through their case that this was not a serious suicide attempt, right? I mean, and there's questions about whether or not somebody's hanging outside the window or not. And so why wasn't this an issue that the Commonwealth could have anticipated would come up?
The position of the Commonwealth isn't that it wasn't a serious suicide attempt. It's that the methods that were chosen were insufficient to achieve the goal. And the reasons for that, we would argue in our closing. I don't think we have to disclose that theory at this point, but we've never said it wasn't a serious suicide attempt. We've never.
Yes, they have. Yes, they have. They have 100% basically said that Lindsay just bops in a wheelchair because she's lazy. They have said that she dangled from the second floor and that her injuries, so what? She had a transection of her spinal column. She had between 100 and 300 cc's of blood in her pleural cavity in each lung. Stop it. Stop it. She is paralyzed. Her cervical spine, C-spine injury, thyroid crushed. She needed sutures, which is treatment for her baby, the superficial injuries. Get out of here. It is 100% disingenuous. Thank you, Judge. Thank you, Judge Honey Bunny, for making good choices and being like, you're basically saying she faked it. She planned to unalive the kids, and then this was all just a plot and plan so that she could go on with her life or not go on with her life. She didn't want to kill herself because it wasn't actually a valid attempt to the Commonwealth. You should have heard, babes, if you never heard the arraignment, bitch, I remember I was like quite literally on the edge of my seat being like, stop it. Oh my God. And she's in the hospital bed. She got a mask on her face. And I'm like, well, wait a minute. This seems a little fucked up. And they're like, yeah, she did this all in. And now she's just laying in this bed like oh, she's some asshole. Look at her just laying in that bed. She's like, I can't move my feet. And that is 100% what the Commonwealth has done this entire time. Minimize. Provide input where they didn't know. You have no idea what the order of operations, God forgive me, but what those children were taken out of this earth, in what order. You don't know. You have to have a curative instruction for that because of your big mouth. So stop. It's a horrific case. This is hard. Nobody forgets those beautiful children. Nobody. The facts are there is a maternal health crisis in this country. And every 10 years we get a case and everybody gets up in arms and they say, oh, we really need change. And then no change comes. That's what I want to be different this time. For Cora, for Dawson, for Callan. And I know that Kevin Ruddington tomorrow is going to bust this psychiatrist right where the sun don't shine. And every theory and every documented word and every undocumented word will be picked apart. A baby psychiatrist should not have been making these massive med changes unsupervised, no precepting, virtually for 4 months. And also, may the Lord be with you, Jennifer Tufts, as you go forward in your civil case. You're gonna need it because you were negligent, in my opinion. And the proof is everywhere. All right, babes, let's go through. That's a lot, but tomorrow, just bear with me. You'll get through it. And these witnesses are going to be what, in my opinion, makes or breaks the entire case. The Commonwealth continues to go through their rinse and repeat cycle. And it's why are we, this has already been presented. This is all cumulative. We keep just giving additional information, which is heartbreaking. Let's get to the meat and potatoes. It's this. It's her. Thank you so much, Grizzly Girl. And to the Truth Drops, thank you for 440 joules for an unk alert. And to Donna Williams, 3094, gave 1,000 joules for a corgi bum. Do. Bring it back old school. Bamber, thank you for being a member for 9 months. Happy to see your lovely face, babe. And to Kristen, who has been a member at my house for 6 months, non-consensually, actually, for a couple of those months, but she's back. Your algorithm isn't telling you to check your messages. I'm going to check my messages on the DMs. On the Twitter, will do. 10, I love Drake May, member for 6 months at Nurse Kim's house. NK, love NK Lives. Thanks for covering from a nurse point of view. Happy Sunday. Happy Sunday, babe. And to Rocketchick 71, 10 joules of floating heart. And to my Chase babes, 10 joules, floating hearts. No one's getting floating hearts more than Tabby XO. Love it. Emily C, we have to bring this back. She became a YouTube member. She used to be at my house and now she's back. Diane G, the OG Diane G, has gifted 5 non-consensual Nurse Kim memberships. Get ready to dole them out like we're dancing for ones. Where at the Centerfolds in Worcester. M3 TAG Ghost gave me a gold coin. I won't spend the gold doubloons everywhere. Muzzolina, thank you for 2 joules of a silver star. And Muzzolina V, thank you for $4.99. I don't want to be a burden vibes from LC. I should be able to do this, or I wouldn't say it's severe equals other people have it worse. Yeah, the cross to bear. Isn't that every mother's cross to bear? You're like, oh, this sucks, but there's a pediatric unit at my hospital with kids on an oncology floor. I should probably figure it out. It can't be that bad. I'm weak because I need help. Even though you're not, but you're able to tell other people, hey, if it was a patient, if it was a friend, if it was a family member, she would have been like, babe, go get help. I'm right here. What can I do? She would have probably started a meal train. She would have had a lasagna made for somebody and been like, can you take a nap? But she couldn't. And I totally get that vibe from her too. It's I can handle it. I can do it. I can get through it. We always do. And then we talk about it afterwards. Oh, wait, that's my trauma, not hers. But you know what I'm saying? You've got to get to the other side and then you can tell people what you were going through. I think so. And to Chadwick, thank you for 200 joules of a flow state. Chad again, 550 joules of a shopping cart. We go to Market Basket. Maynard, and thank you for thanking me for our discussion. Gentelia gave us a clapping seal, like we're at SeaWorld. And Miss Priss says such an important discussion for mental health. I think it's really going to change case law too. I think this is going to set a precedent. And maybe, just maybe, this is the case that there is change. Oh, Emily C. I just had to prove that I already was a member. 10 months non-consensually at Nurse Kim's house. Babe, I bid you adieu. We're in a full-blown relationship at this point. What are you doing? Are we doing something for our 1 year? Congratulations. You did a beautiful job on the fundraiser yesterday for Adam Deitch. And Emily C. is single-handedly saving Norfolk County, okay? Maybe Adam Deitch needs to hire you for his transition team. And Megan, my A1, has been here for 2 months and said this was great coverage. Thank you, Nurse Kim. Thank you, babe. And to my E-Chase, thank you for covering this. Of course, my pleasure, babes. Thank you for showing up. Thank you for hanging out with me. And thank you to Sassy Unicorn for 10 jewels of a floating heart. Be good to yourselves. Be good to each other. Tomorrow we will hug after everything and see what kind of day it's going to be in this trial. I think it's going to be fireworks. I think it's going to be bombshells. I think it's going to be a tango that a lot of people don't see coming from the likes of attorney Kevin Reddington. All right, babes. Talk to you soon. Bye.
What's gotten into the people in the world today? Common sense of man is pushed out of the way. No one's filtering the wild shit they say. Don't seem to have Tourette's, so why you so cray-cray? You're not my friend, not my fam, not on my level, not my jam. You're the goddamn devil, I don't give a damn. When you drive through Salem, they scream, burn that witch. So shut all the way the fuck up, you dumb bitch. Please God, dear Lord, tell them to sign offline and hop on to all the good dick that you can find. Let everyone get dick down consensually. Go get you some instead of worrying about me. Everybody should be worshipped centrally. Hopefully you'll realize eventually. Get out of my face, get out of my chat. You're an ostrich, bitch, what you think about that? Why you all way up inside my grill today? I don't think you have Tourette's, so why are you talking cray cray? You're not my friend, not my fam, not on my level, not my jam. You goddamn devil, I don't give a damn. When you're driving through Salem, they scream, burn the witch. Shut all the way the fuck up, you dumb bitch. Get out of my face, get out of my chat. You're an ostrich, bitch, what you think about that? Nurse Kim will preach it, Jimmy will teach it, other Mary B and me will art it. Last and least, young jerks will fart it. This was adapted from a non-ironic valid truth, Kimmy. It's my homework for Jimmy. Shout out to Tish, Kylie, and the other Mary B. Shout out to Zach, Mo S, Nicola, and Queen Valerie. Shout out to Miss Jess, Emily C, and MC Kazi G. Shout out to Ray from Dallas, Fervent, Jess, Glera, OBN TV.